Okay, welcome back to the deep dive. We've got some great source material sent in, focusing on a really key topic if you're prepping for the MSRA exam, sebaceous cysts. We're going to take what you've given us and, really boil it down to the essentials, the high-yield stuff you absolutely need.
Exactly. We're cutting straight to the core here. We'll break down the crucial details, especially on epidermoid and pillar cysts, what they are, why they pop up, what they look like, and crucially, how you'll manage them, all geared towards that exam.
Perfect. So let's just dive right in. When we talk about these cysts, sebaceous, epidermoid, pillar, what exactly are we dealing with?
Okay, so at the most basic level, they're described as non-cancerous lumps. They form just beneath the skin surface.
Hmm.
They're super common, and thankfully, almost always benign. Nothing usually to worry about malignancy-wise.
Right. And they have a certain look, don't they?
They do. Typically round, maybe dome-shaped.
Yeah.
And inside, you might find this yellowish kind of foul-smelling cheesy material that's keratin buildup or sebum. And a really classic sign, you'll often see it right on the skin over the lump, is a little central opening. We call that a punctum.
Okay, so a benign lump, possibly smelly contents, and often that central dot. Got it. You specifically mentioned epidermoid and pillar cysts, though. Are they basically the same?
Not quite the same origin, and it's a useful difference to know for the exam. Epidermoid cysts come from epidermal cells, the skin surface cells that somehow end up down in the dermis, the deeper layer, maybe trapped there.
Okay.
Whereas pillar cysts, sometimes called tricholemal cysts, they actually arise from a specific part of the hair follicle, the outer root sheath.
Ah, okay. So slightly different starting points cell-wise, but they end up looking pretty similar under the skin.
Exactly that. Clinically, they can be hard to tell apart just by looking, and you'll hear the term sebaceous cyst used broadly, but technically that should mean from the sebaceous gland itself. But really, epidermoid and pilar are the common ones people mean, and they can appear almost anywhere: scalp, ears, back, face, neck, arms, trunk, even genital regions. The sources even mention less common spots like inside the mouth or eyes, palms, soles, even under the fingernails.
Wow, okay. Quite the range. Is there one place that's particularly important to remember?
Well, the scalp is definitely one to flag. We'll circle back to why later, potential deeper issues, but for now, just remember they're widespread. And a key point for management, which we'll get to, is removing the entire cyst wall, the whole capsule. That's vital to stop it coming back.
Makes sense. Prevent recurrence. So why do they even form? What causes them? The etiology.
The basic problem is usually some kind of blockage or damage. So for what people loosely call sebaceous cysts, maybe the duct of the sebaceous gland gets blocked. For epidermoid and pillar, it's more about those skin cells or hair follicle parts getting trapped or blocked off somehow.
And are there things that make that blockage or damage more likely?
Yeah, the sources list a few factors. Things like minor skin trauma, a cut or scrape. Hormonal changes can play a role, maybe excessive sebum production, which kind of makes sense. And genetics can be involved sometimes too, though honestly, often you don't pinpoint an exact cause.
Right. So building on that, any specific risk factors or
Sure.
conditions linked to them?
Definitely. A history of acne seems to increase the risk. People with generally oily skin might be more prone. And a family history of similar cystic conditions is also mentioned.
And there was that one specific genetic condition highlighted in the sources, Gardner syndrome.
Absolutely. Huge one for exams. Gardner Syndrome, it's an autosomal dominant condition, and yeah, epidermoid cysts are a big feature, but it's way more than just skin cysts. It includes familial adenomatous polyposis FAP of the colon. That means hundreds, maybe thousands of polyps in the bowel. Very high cancer risk there. Plus, you get other things like osteomas, these benign bone growths, often skull or jaw, and other soft tissue tumors.
Wow. So seeing lots of these cysts, particularly in certain people, could be a signpost for serious internal stuff.
Precisely. And the high yield bit. The cysts in Gardner's often show up early, think teenage years, and they tend to be on the face and extremities, maybe more so than typical sporadic cysts in older adults. So let's do a quick scenario. Say a 16-year-old presents multiple small, firm lumps, cheeks, arms. What genetic condition jumps to the top of your list?
Gardner syndrome, definitely. That link between the skin and the potential bowel issues is critical.
Okay, let's switch gears a bit. We know why they start, but how do they actually form? The pathophysiology. Think of it like a blocked drain. Simple analogy, but it works. The opening, whether it's a gland duct or hair follicle, gets blocked.
Okay.
So the stuff that should get out, sebum, keratin, it can't. It gets trapped behind the blockage.
And that buildup makes the lump.
Exactly. It forms a little pocket, a closed sac or cyst right under the skin,
Mm-hmm.
and it just keeps accumulating material. Over time, it can get bigger, the contents can get thicker, denser.
And that's where trouble can start.
Yeah, because that trapped stuff is a nice environment for bacteria sometimes. It can get inflamed or
Mm-hmm.
infected, and that's when it becomes red, painful, swollen, tender.
Got it. Blockage, buildup, forms the cyst. Infection is a complication. Makes sense. So if you see a lump under the skin, especially in an exam, what else needs to be on your differential list? What do you need to rule out?
Key area, this.
Okay.
You need to know what else it could be. Lipomas are probably number one, benign fatty lumps, but they tend to feel softer than cysts, often larger too.
Okay, softer is lipoma. What
Yeah.
else?
Neurofibromas were mentioned. They're from nerve sheath cells. They tend to feel harder, firmer. And sometimes, like the cysts and Gardner's, they can be multiple, which might point towards neurofibromatosis, another syndrome, but Gardner's is the specific link for epidermoid cysts mentioned here.
Right.
And then there's the infected scenario. If it's red, hot, painful, is it an infected cyst or is it a primary abscess, just a collection of pus that formed on its own?
Okay, so soft large syncytioma, hard multiple neurofibroma, or consider a syndrome, hot painful infected cyst or primary abscess. And always keep Gardner's in mind for those multiple facial extremity cysts in younger people. Clear. How common are we talking here? In the UK, say. Epidemiology.
The sources don't give an exact number, but they stress that epidermoid and pillar cysts are very common, really common. They can happen at any age, but you see them most often in adults, especially 20s and 30s.
Any gender difference noted?
Yep, about twice as common in men compared to women. And just as a side note, simple epidermoid cysts can sometimes run in families, even without Gardner's.
Okay, good to know. Let's talk clinical features. Patient walks in. What do you see? What do you feel?
Well, the classic finding is a painless lump. Unless it gets inflamed or infected, it usually doesn't hurt. It feels pretty firm, typically round or dome-like in shape. And often it's mobile. You can wiggle it slightly under the skin.
What about the skin over it?
Can look totally normal, or maybe slightly off color, whitish or yellowish.
Mm-hmm.
Size varies hugely, tiny little things up to several centimeters across. And don't forget that punctum, that little central pore. Seeing that is a big clue it's a cyst.
Right, the punctum.
And if it ruptures or you express it, you might get that characteristic cheesy, slightly foul-smelling material. That's typical for epidermoid and pillar types. Color-wise, usually skin-colored, yellowish, white. Can look darker, pigmented in people with darker skin tones.
And how does it all change if it gets infected or inflamed?
Oh, big difference then. It'll be red evavitus, tender to touch, painful, swollen. If it actually forms an abscess, it'll feel fluctuant, like there's fluid pus inside. And remember, location matters too. Cysts in tricky spots like the genitals or under a nail subungual that can cause pain just from pressure or activity, even without infection. A subungual one might even change the nail shape. Palmoplantar ones are also noted as a specific group.
Okay, maybe a quick memory tip here. For the common cyst features, think PCP. Painless, less infected. Cheese-like contents, punctum. Simple, but might stick. Let's try a quick exam style check. 40-year-old woman, small, painless, mobile lump on her neck. You examine it, notice a tiny dark spot right in the middle. Most likely diagnosis.
Even it's painless, mobile, and has that punctum.
Yeah.
Yeah, sebaceous cyst, probably epidermoid is right up there. Okay, my turn. Patient has a lump on their back. Had it for years, never bothered them. Suddenly, over the last day or two, it's become really red-hot, throbbing pain. What's likely happened?
Sounds like that long-standing quiet cyst has got infected. Good. So, we've seen the patient, examined the lump. We think it's a cyst. Do we need special tests? Investigations.
Right, this is really key exam territory. The sources are clear. Diagnosis is typically clinical. Often, you can be pretty confident just from the history and what you feel and see.
So when would you investigate further?
Well, sometimes imaging, like ultrasound, maybe MRI, might be useful, perhaps if it's really large or at a funny place near important structures. Or if you're worried about how deep it goes, like those scalp cysts we mentioned, possibly connecting deeper. And biopsy, that's really reserved for when you suspect malignancy. If it looks weird, growing fast, ulcerated, then you'd plan an excision biopsy, take it out and send it to the lab. But the sources explicitly say things like fine needle aspiration or biopsy just to diagnose a typical cyst.
Right.
Rarely needed.
Right.
So the big takeaway on investigations, clinical diagnosis first and foremost. Test only if it's atypical, suspicious, or in a tricky spot.
Okay, clinical diagnosis it is, usually. So let's say it is a typical benign cyst. How do you manage it? What's the plan?
The first principle, strongly stated, is that these often don't need any treatment at all. If it's small, not bothering the patient, not causing cosmetic issues, just leaving it alone, watchful waiting is perfectly fine.
But what if it is bothering them or causing problems?
Then, if treatment is needed, maybe it's painful, getting infected repeatedly, interfering with life, or the patient just hates the look of it, the main approach is surgical excision, removing it.
And you mentioned before about getting the whole thing out.
Absolutely vital. The sources hammer this home. To stop it coming back, you must remove the entire cyst, including its capsule, the wall around it, leave a bit of wall behind, and it'll likely just fill up again.
What about if it's acutely inflamed or infected right now?
Yeah, that changes the immediate plan. If it's red raw and angry, especially if there's an abscess, you often deal with the infection first. That might mean incision and drainage, letting the pus out, plus antibiotics. Then you probably plan to excise the cyst properly later, once the inflammation has calmed down. Spontaneous resolution can happen, apparently, but it's seen as less definitive. Excision is the gold standard if removal is indicated, and specifically for epidermoid pillar cyst antibiotics, if infected, you can express the contents if it ruptures. Interestingly, if it's inflamed but not infected, sometimes a steroid injection can calm it down, though you'd still need excision later for removal.
Can you briefly outline the steps for excision?
Sure. Standard minor ops procedure, really. Informed consent first, then local anesthetic to numb the area. Make an incision, usually elliptical, over the cyst. Carefully dissect it out, making sure you get that whole capsule. Then close the skin. And the really crucial step afterwards. Anything you excise should always be sent for histology. Yeah, always. Even if it looks totally benign. Standard practice.
Okay, so quick summary for management triggers. Think SCC, symptomatic, cosmetic concern, or complicated, like infection. If yes, treatment's probably needed. Definitive is usually excision. Get the whole capsule, send for histology. Got it. What's the general outlook then? Prognosis.
Generally, it's excellent. Really good prognosis.
Why so good?
Because surgical removal, done properly, is curative in most cases. If you get that entire cyst and capsule out, recurrence is pretty rare. Complications like infection or scarring can happen, sure, but good management minimizes those risks.
Right. And speaking of complications, although the outlook's good, what potential problems can arise?
Well, infection is the big one we've mentioned. Pain, redness, swelling. Maybe leading to an abscess needing drainage, antibiotics. Even without infection, it can just be a persistent lump that causes discomfort or gets in the way.
And after surgery or messing with it?
You can get scarring, obviously, or other skin changes at the site. And the sources specifically mention anxiety and cosmetic concerns too, especially for facial cysts or very visible ones. That distress is real for patients.
And the elephant in the room for any lump cancer risk. Malignant transformation.
Okay, the sources are very reassuring here. Malignant change in a standard sebaceous epidermoid or pillar cyst is very rare, extremely uncommon. It's not something high on the worry list for a typical presentation. However, remember that high-yield point about cysts on the skull?
Ah, yes, the potential deeper connection.
Exactly. The sources highlight that these can rarely have connections deeper down into the skull bone, intraosseous, or even potentially towards the brain, intracranial. It's unusual, but it means if you see a scalp cyst that seems fixed or just feels odd, you might need imaging, like an MRI, before attempting removal. It needs careful handling, awareness of that possibility.
That's a really crucial detail to file away. Location matters. A scalp cyst isn't always just skin deep.
Okay, I think we've covered the journey pretty thoroughly there. Definition, causes, risks like Gardner's, how they form, differentials, features, diagnosis, management, prognosis, and those complications, including that important scalp point, all with the MSRA in mind. Yeah, absolutely. And thinking about that point about malignancy being rare, yet we always send for histology. Why do you think that is? Why is it still standard practice according to guidelines? That's worth pondering. Or, going back to the skull cyst, what specific finding on examination might make you more suspicious and lean towards imaging compared to just a simple mobile scalp lump? Good things to think about.
Excellent points for reflection. That wraps up our deep dive on sebaceous cysts, epidermoid, and pillar types, hitting the key takeaways from the sources for your MSRA revision.
Keep going through those clinical scenarios, linking the features to the management. You're building that knowledge base. Good work.
For more free MSRA revision resources, definitely visit freemsra.com, and for the full premium revision toolkit, head over to passthemsra.com.